Hello, my name is Dr. Dan Hindley and I work as a community paediatrician in Bolton in Greater Manchester. This is the third of 3 e-lectures on community paediatrics based on questions from the extensive past test database. I really hope that these lectures will provide you with some insight into the sort of questions you can expect to have to answer on this aspect of paediatrics for MRC PCH Part 1. This lecture covers examples of questions about immunisation and public health issues. The key learning objectives for your revision in this subject and from this lecture should include a knowledge of the current immunisation schedule, knowledge of contraindications to immunisation, revision of current health screening recommendations for children, and understanding of illness prevention and health promotion programmes. So, question 1. Which vaccination is not included in the 2, 3 and 4 month ages of a child according to the UK immunisation schedule? A. Polio. B. Hib. C. DTP. D. Men-C. And E. BCG. The immunisations given at 2, 3 and 4 months include all of the 4A to D above. They also include immunisation against the pneumococcus. BCG is usually given at birth in high-risk neonates or at ages 10 to 14, although this is being phased out. So the answer to this question is A, B, C and D are all false and E is true. Question 2. Which of the following are absolute contraindications to pertussis immunisation? A. Epilepsy. B. A family history of convulsions after immunisation. C. Eczema. D. Autism. E. A previous severe local reaction to immunisation. There are many myths about the contraindications to different immunisations, particularly pertussis immunisation. Since 2006, acellular pertussis vaccines have been used for routine immunisation in the UK, and this change, together with an assessment of vaccine reactions, has led to a significant change in the contraindications and warnings relating to pertussis immunisation. The only remaining absolute contraindications for pertussis-containing vaccines are confirmed anaphylactic reaction to a previous dose of pertussis-containing vaccine, or confirmed anaphylactic reaction to neomycin, streptomycin or polymyxin B, which may be present in trace amounts in the vaccine. Of particular note, and in contrast to previous advice, immunisation with pertussis-containing vaccines should not be withheld despite a previous history of convulsions, high fever, hypotonic hypo-responsive episodes, persistent crying, screaming or severe local reactions following immunisation. By the time of school entry, children in the UK should have received 4 doses of pertussis-containing vaccines, with the 3 at 2, 3 and 4 months and a booster at 3.5 to 4 years. The booster dose at school entry was added in 2006. At the same time, the change was made from whole cell to acellular pertussis component vaccines. So, the answer to all the above on this question is that they're all false. Question 3. MMR contraindications include which of the following? A. A child treated with 2 mg per kilogram per day of prednisolone. B. Children with a history of neonatal seizures. C. Previous vomiting after egg ingestion. D. History of febrile convulsions. And E. Severe eczema. After pertussis, MMR has perhaps and most recently been the immunisation which has attracted most adverse attention, with the result that immunisation levels have fallen and measles is once again becoming more common. Contraindications to MMR include acute fever, recent immunoglobulin administration, administration of another live vaccine in the past 3 weeks, immunosuppression, and allergy to neomycin or kanamycin, and also pregnancy. So children who are on long-term prednisolone should not be given the MMR. There's a lot of confusion about whether children with egg allergy can receive MMR. In children with a significant history of an anaphylactic reaction to eggs, or who've had an egg allergy and chronic severe asthma, it's recommended that vaccination should be given in hospital under observation. However, the vaccine is not contraindicated in such patients, and most patients will be able to have the MMR without complication. So the answers to this question are: A is true, B is false, C is false, D is false, and E is false. Question 4. Which of the following are true regarding BCG vaccination? A. Efficacy is demonstrated by a hypersensitivity response to vaccine administration. B. It is contraindicated in neonates. C. It offers protection against infection with Mycobacterium bovis as well as Mycobacterium tuberculosis. D. It should be injected subcutaneously. E. It contains a live attenuated virus. The MAN2 test results in hypersensitivity responses. BCG, which stands for Bacillus of Calmette and Guerin, is a vaccine against tuberculosis that is prepared from a strain of the attenuated live bovine tuberculosis bacillus, Mycobacterium bovis. This has lost its virulence in humans through serial propagation in artificial media. The bacilli retain sufficient immunogenicity to behave as a reasonably effective vaccine for the prevention of human tuberculosis, particularly in the prevention of TB meningitis and disseminated disease in early childhood. Protection against pulmonary disease in later life is less certain. BCG vaccine should always be given intradermally, as subcutaneous administration is likely to be associated with adverse effects, including local abscess formation and suppurative lymphadenitis. The MAN2 test results in a cutaneous hypersensitivity response to administered PPD, but neither a cutaneous response to the vaccine or to PPD are sufficient or required to demonstrate vaccine efficiency. So the answers to this question are: A is false, B is false, C is true, D is false, E is true. Next question is question 5. Consider the options presented below. What screening does not occur in the United Kingdom? A. A heel prick test to screen for congenital hypothyroidism. B. Red reflex to screen for congenital cataract. C. Echocardiogram in children at 6 weeks to screen for or diagnose cardiac structural disease. D. The otoacoustic admission to screen for hearing impairment. E. The heel prick test to screen for phenylketonuria. The number of conditions being screened for is continually changing. Some of the recent additions have been for universal screening for cystic fibrosis on the heel prick test. The conditions that are screened for vary from region to region, and the methods used also change. The routine neonatal and 6 weeks check are used to screen for cataracts and dislocated hips and for heart murmurs. Echocardiograms at 6 weeks are not used to screen for heart disease. The otoacoustic emission test is now used as the screening test in the Universal Hearing Impairment Screening Program. So, the answers to this slide are: A is false, B is false, C is true, D is false, and E is false. Question 6. Advantages of breastfeeding are: A. Reduces the risk of bacterial contamination. B, protection of infection via maternal antibody, brackets IgE, close brackets. C, promotion of colonization with lactobacillus. D, improves maternal bonding. E, is cheaper. This is a very popular question, and all undergraduates will have been taught the benefits of breastfeeding. It's also a popular question in the membership exam. And there are many economical, social and medical advantages of breastfeeding. All of these above are true apart from B. The maternal antibodies in breast milk are IgA, not IgE. So A is true, B is false, C is true, D is true, and E is true. Question 7. A 12-year-old girl was diagnosed with meningococcal meningitis. She was treated successfully and made a full recovery. Appropriate further action would include which of the following? A. Treatment of the immediate family with rifampicin. B. Treatment of the entire class with rifampicin. C. Immediate notification to the Public Health Laboratory Service. D. Nasal swabbing of the child's entire class to detect carriers. E. Provision of information leaflets to the child's school. People who have come into close contact with meningococcal meningitis and or meningococcal septicemia require antibiotics. Close contacts are people who are living or sleeping in the same household or have had intimate contact / kissed the patient. School friends and colleagues of the patient with meningococcal disease are rarely at higher risk, but obviously a child's classmates and their parents will have concerns when they find out about a child having had meningococcal disease. For that reason, provision of information leaflets to the child's school is always a good idea. So the answers to this slide are: A is true, B is false, C is true, D is false, and E is true. And question 8, regarding hand washing. A. Ordinary soap and water is not effective against bacteria. B. Staff should wash hands after every patient contact. C. Staff should wash hands before examining every patient. D. Hand transmission is a major source of serious infection. E. Pseudomonas aeruginosa cannot be removed with the use of alcohol rubs. Formal hand washing with soap and water is required when there is soiling. When there is none, the Hand Hygiene Liaison Group now advocates that staff should use an alcohol glycerol hand rub between patients. The answers to this question are: A is false, B is true, C is true, D is true, and E is false. So, the key learning points from this lecture are that epilepsy is not a contraindication to pertussis or other immunisation. Egg allergy is not a contraindication to the MMR. The immunisation schedule and advice frequently changes and evolves. It's important that you understand the criteria for screening, and it's always worth being aware of the benefits of breastfeeding when doing multiple choice questions in exams. The BNF holds the current immunisation schedule, and this is often being added to or tinkered with. If you need more information or details about immunisation, then the Green Book is published by the Department of Health, and it has a lot of useful information regarding commonly asked immunisation queries. If you just Google Green Book and then go to the website on the Department of Health website, you'll find it there. For a screening program to be successful, it needs to meet the criteria for screening, and it's worth revising these. These include that the condition should be an important disease with a known natural history, there should be a good test for the condition, there should be a useful intervention, and that intervention and testing should be cost effective. This is the end of the third Community Paediatrics lecture. Lecture 1 covers child development and Lecture 2 child protection. Good luck with your studies and with the exam.